I am Dr. Buddhadev Dutta, specialist in medicine and practicing in the community hospital at Jorhat. So I've been retired from the government servant in the year 2014, February, 28 February. Now I've been practicing internal medicine in a hospital named Niramoy Hospital as a physician. So today my topic of discussion is diabetes with established cardiovascular disease, as I have been asked for to say something regarding this ailment. So in the very beginning, I like to tell that India is going to be the diabetic capital of the world. An estimated global prevalence of diabetes mellitus in the year 2021 in the age group of 20 to 79 years is 537 million. And it is projected that in the year 2045, it will be 783 million people. So it's a quite big problem for us, and it is draining all the resources. And the major problem, the diabetes, especially type 2 diabetes, it is associated with the cardiovascular disease. And the cardiovascular disease is the leading cause of morbidity and mortality in adults with type 2 diabetes mellitus, and which is estimated to occur 12 to 15 years earlier in people with type 2 diabetes mellitus. The excess risk for atherosclerotic cardiovascular disease in patients with type 2 diabetes has been estimated to be at least twice that of those without diabetes. Framingham offspring study suggested 2/3 of the patients of diabetes mellitus, they have subclinical cardiovascular disease. Diabetes mellitus increases the risk of subclinical cardiovascular disease by 4.3-fold. Subclinical cardiovascular disease increases the risk of cardiovascular event by 2-fold. The vascular wall in patients with diabetes is well known to have advanced atherosclerosis. EMPA-HEART, effects of empagliflozin on cardiac structure, function, and circulating biomarkers in patients with type 2 diabetes. In patients with type 2 diabetes showed that empagliflozin resulted in early and significant reduction in the left ventricular mass regression as detected by cardiac MRI, and also suggests that reverse cardiac remodeling may be a possible contributor to the cardioprotective effects of SGLT2 inhibitors. In 2015, the era of evolving dimension of cardiovascular care in type 2 diabetes management began with the EMPA-REG outcome study, which demonstrated significant benefits of empagliflozin on cardiovascular mortality by 38% cardiovascular events, as well as MASH in type 2 diabetes and cardiovascular disease. All types of cardiovascular deaths were reduced with empagliflozin. More prominent absolute benefits were observed for heart failure-related death and sudden cardiac death. The post-hoc analysis of EMPA-REG demonstrated consistent cardiovascular mortality benefit irrespective of prior cardiovascular events, MI or stroke, heart failure burden, CKD, baseline HbA1c level, control of multiple cardiovascular risk factors, or background use of metformin. Several mechanisms have been proposed for cardiovascular effects of SGLT2 inhibitors, including osmotic diuresis, natriuresis leading to blood pressure lowering, decrease of arterial stiffness and vascular resistance, decrease in weight, and decrease in uric acid and oxidative stress. It has also been reported that SGLT2 inhibitors promote reverse cardiac remodeling, improve myocardial energetics and filling conditions, reduce left ventricular wall stress and mass, and reduce the blood pressure and arterial stiffness. The EMPA-HEART CardioLink 6 study demonstrated that empagliflozin could produce remodeling in type 2 diabetes mellitus and stable coronary artery disease. In Carmelina and Carolina trial, linagliptin has also demonstrated cardiovascular and renal safety, secondary endpoint of linagliptin versus placebo, or active comparator when added to standard care in patients with type 2 diabetes mellitus who were at high risk of vascular complications. And especially the empagliflozin is a very good sodium glucose cotransporter inhibitor and a unique mechanism of action leading to excretion of glucose in the urine and subsequent lowering of the plasma glucose. The mechanism of independent of beta cell function, and thus these agents are effective for treatment of type 2 diabetes mellitus at theoretically any disease state. This class should not confer any additional risk of hypoglycemia unless combined with insulin or insulin secretagogue, and has the potential to be combined with other classes of glucose-lowering agents. Empagliflozin is one of the 3 currently approved SGLT2 inhibitors in the United States and has shown a favorable benefit-risk ratio in phase 3 clinical trials as monotherapy and as add-on to other glucose-lowering therapy in broad patient populations. In addition to its glucose-lowering effects, empagliflozin has been shown to reduce body weight and blood pressure without compensatory increase in the heart rate. Moreover, on the top of standard of care, empagliflozin is the first glucose-lowering agent to demonstrate cardiovascular risk reduction in patients at high risk of cardiovascular disease in prospective outcome trial. A 14% reduction in the risk of 3-point composite endpoints of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. Like other SGLT2 inhibitors, empagliflozin associated with a higher rate of global genetic mycotic infections. But this is not a major problem, and it reduces fatal MI and a non-fatal MI and stroke also. Like other SGLT2 inhibitors, empagliflozin associated with a higher rate of genital mycotic infection and than the placebo, and the potential of volume depletion associated events. Because in the heart failure, whether the patient is diabetic or not, the use of empagliflozin is justified. This use extends beyond the spectrum of diabetes. As you know, the heart failure is a worldwide problem. It is frequent, progressive, deadly, and costly. And the 64 million people are suffering from heart failure at present, out of which 1 to 2% of the total global population. Up to 30% of the global population will have heart failure by 2025. And it is progressive. 9 out of 10 patients, they have symptoms despite treatment. It is deadly also. 5-year mortality of the heart failure exceeds prostatic cancer, and it is costly. 10% of the patients die during the first heart failure admissions, while survival after second hospitalization is less than 18 months. The goals of therapy in heart failure is to increase the survival. And second is reduce hospital admission. Third, make the people live longer. Increase survival, they reduce the mortality and premature death, ideally by reducing two main most sudden cardiac death and death from the progressive heart failure, that is pump failure. And reduce hospital admission. Apart from being very unpleasant for patients, distressing for the families and costly, is a bad prognostic development, which is also true of any episode of worsening of heart failure requiring intensification of therapy. And make people feel better, improve the symptoms, quality of life, or at least slow the rate of deterioration, allow the people to continue to lead to as normal and unrestricted life as possible. In the pharmacological therapy, we have some drugs in our armamentarium. First is your angiotensin converting enzyme inhibitor, then ARB, then we can add beta blocker, then MRA, mineralocorticoid receptor antagonist. And the neprilysin inhibitor, as per paradigm HF trial, and SGLT2 inhibitor you can use, and vericiguat you can use. Principles and pathophysiological targets of our heart failure with reduced ejection fraction pharmacotherapy. There are 5 pathways, and modulation of the 5 pathways shown to improve outcome in the general heart failure with reduced ejection fraction population. One is angiotensin 2 modulation, then norepinephrine, aldosterone, neprilysin, SGLT. So here comes the role of SGLT2 inhibitors. And there are 4 drugs. One is ARNI, second is your beta blocker, third is MRA, and fourth is SGLT2 inhibitor, dapagliflozin or empagliflozin. And 3 others like ivabradine, hydralazine, nitrate, and vericiguat. And the 5 pillars of heart failure with fraction therapy in 2020, these are the ACE or ARB, the neprilysin inhibitor, beta blocker, MRA, SGLT2 inhibitor. And the 4 pills, that is ACE inhibitor or neprilysin inhibitor, and second beta blocker, third MRA, and fourth is SGLT2 inhibitors. So SGLT2 inhibitors, especially the empagliflozin, personally I've been getting a very good response, mainly in combination with linagliptin. I've been using as an add-on therapy to the metformin, other drugs. And the patients are responding very well. So in case of extremely low GFR, I have not yet used. Not only time will decide the outcome of the patients. And this is for today. Do you have anything to ask?
Thank you.